everyone, and thank you very mumuch, Dr. Jessica and Professor G, and especially thank you for the organizing committee, Professor John Won and team for the kind invitations to share in this meeting. It's an honor to stand here with many esteemed colleagues. So today I'm tasked to share about the hepatitis C elimination from the perspective of pregnancy and childhood. This is the outline of my lecture today. I will talk about why pregnant women is a particular interest population in the setting of hepatitis C eliminations. I will talk about how this topic from the perspective of the global burden and prevalence. I will discuss the maternal to child transmission and what is the clinical impact. And I'll finally finish my talk by providing the safety data on the direct-acting antiviral in this population. So, the reason why pregnant women is a unique population in the hepatitis C eliminations is that this population is often kind of a neglected populations, and most hepatitis C infections, up to 80%, they are actually asymptomatic, and often they are undiagnosed, particularly in this population of pregnant women. And being pregnant is a unique opportunity because this is a time where most of the women will actually get contact with the healthcare, which does provide a platform and opportunity for hepatitis C diagnosis and hopefully subsequent treatment. And diagnosis and treatment in these populations has dual benefits, both by providing the maternal cure and preventing pediatric hepatitis C infection. I will first start by sharing the global burden of hepatitis C among the pregnant women. We recently completed a systematic review and a meta-analysis involving more than 300 million pregnant women of more than 333 studies. What we found is that the pooled global prevalence of the hepatitis C viremia in pregnant women is about 1.3%. This estimate has been increasing over the years. You see at the bottom here. So the estimate has been increasing. And over the years, this is the data from US, and the increase is particularly higher among the marginalized populations, and by ethnicity, this is more often seen in the Americans, Indians, and also the Alaska Native. Similar with the general populations where you expect hepatitis C, the hepatitis C prevalence is also higher among population with a higher drug use, over here, higher drug use, substance abuse, and also tobacco use as well. The figure on the right, the table on the right was actually the data from the Affiliation population in US, and what they found that the hepatitis C prevalence among pregnant women, particularly in this population which is haunted by the opioid problems, the infection rate is about close to 12%, and 12% is about 35 times higher than the national rate of what you expect in the United States. Hepatitis C infection in pregnant women carries adverse effect both from maternal and also the pregnancy outcomes. On the left, you see that from our systematic review and meta-analysis, we found that hepatitis C infection in the pregnant setting results in higher risk of antepartum hemorrhage, higher risk of preterm delivery, and also higher risk of intrahepatic cholestasis. From the neonatal perspective, it also results in a higher risk of neonatal infections and also small to gestational age. And this is it is thought to be due to the placenta insufficiency as a result of hepatitis C infections in the trophoblast. And on the right, you then see the burden of a hepatitis C-related cirrhosis among women with a reproductive age. This is the data from the global burden of disease, range between 1990 to 2019. Rate is bad, so the country in the red showing an increasing incidence of hepatitis C-related cirrhosis among women with reproductive age. And this, you can see from the map itself, it doesn't discriminate, and it even affects a country with a high country who is already developed, suggesting that even among country who is developed, there are gaps in terms of diagnosis and treatment in these populations. Let's talk about maternal to child transmissions and how common it is. So from our recent meta-analysis, we found that the global pooled prevalence among the HCV viremic mothers range between 7 to 9%. The more accurate the estimate is probably closer to 7. You see that when you look at the bigger studies, the estimate are more consistent around 7. And we specifically look at HCV viremic mothers because detectable maternal hepatitis C, the RNA is necessary drivers for maternal to child transmissions. And this transfer rate is actually higher among mothers with co-infected with the HIV, up to 3 times more common. The next question really is there a threshold for hepatitis C viremia that makes patients more likely to have maternal to child transmissions? Based on the literature from both the United States and also Canada, it seems like the maternal RNA threshold of more than 6 looks results in higher risk of maternal to child transmissions. From the same studies from Canada in JHEPT, what they found is that mothers who have a HCV RNA less than 3.5 log, none of them have maternal to child transmissions happened, suggesting that these 3.5 log may be a potential threshold to consider when we eventually thinking about treating the pregnant women with a DAA. What this estimate leads to is more than 20,000 vertical transmission of hepatitis C globally every year. This has huge impact because these data only account for children who is still alive at the age of 5. And the risk of maternal to child transmission resulting in vertical transmission is particularly higher in countries who have high HCV prevalence among women with childbearing age, and also a country who has a large population size and high reproduction rate. And these problems particularly affected countries such as Pakistan and Russia, where you have high HCV prevalence among women with childbearing age. Despite having a huge population size such as in India and China, because the HCV prevalence among women with a reproductive age is low, you can see that the burden are substantially lower compared to countries such as Pakistan and Russia. What vertical transmission leads to is infections of HCV in childhood. Let's talk about the long-term outcome data in these populations. So for the longest time, we have always thinking that the long-term outcome in childhood HCV infection is generally good. Very small proportion of patients eventually developed advanced liver disease. The first paper on the left shows that on the follow-up of 10 years, they found 1% of the patients developed decompensated cirrhosis. But as more and more data emerge looking at bigger populations follow-up over the longer period of time, the one on the right here, that was the most recent data published in Journal of Hepatology involving more than 1,000 HCV-infected children. They follow up this cohort for more than 37 years. And what they found is that 1/3 of these patients already have liver cirrhosis at the end of follow-up. Now, 37 years is really a long time for clinical studies. But when you look at the perspective of a childhood HCV infection, this is not that long. Although the durations of suffer under exposure to hepatitis C is the same, you can see that those patients who have a vertical transmission of hepatitis C developed cirrhosis at a significant younger age compared to the counterpart with childhood HCV infections. And the comparator group are those who acquire HCV at the age less than 18 years old. And you can see that the median age of developing cirrhosis is only 34 years. 34 years represents an individual who is currently in perhaps the peak of their career, starting family, socially productive, and which arguably could have been prevented by using highly effective direct antiviral and, of course, good public health policy. This is why HCV screening has been recommended during pregnancy by various professional bodies. Starting from 2018, you can see the recommendations coming from the AASLD and IDSA, and over the years by US Task Force, CDC, American College of Obstetric and Gynecology, and also Society of Maternal and Fetal Medicines, recommending to screen all pregnant women and some of them at each pregnancy to find out whether these patients have hepatitis C infections. But despite the guideline recommendations, HCV screenings remains suboptimal. On the right, you see that among the pregnant women, following the recommendations by professional body, we do see a statistical significant increase in terms of the number of patients screened among pregnant women. That said, the number of pregnant women screened still remains low at the broader perspective. Only a small fraction of pregnant women are actively being screened for hepatitis C. And at the lower part, you see that the screening is also affected by many reasons as well. Data from US suggests that the screening is also affected by the insurance coverage, whereby if you have a private insurance, you are more likely to be screened versus having a Medicaid cover. This is from the perspective of the pregnant women. How about the children? So on the left, you see that the screening among infants with HCV positive mothers is also not as great as well. This is data from the University of Pittsburgh. It's a population-based study involving more than 1,000 HCV-exposed infants. Among them, the group study whether what is the care provided for this group of infants, and also including the hepatitis C infection, hepatitis C screening in these populations. And what they found is that among the children who have received a good childcare service, and even among them, only 30% are being screened. And let alone if you look at the group of children who is not did not receive well child services, the rate significantly dropped to only 5%. Essentially, we are not really screening the hepatitis C, even even though they are infants of HCV positive mothers. When we talk about the screening among hepatitis C among infants, I also wanted to bring up this interesting phenomenon. It is known that there is spontaneous clearance of hepatitis C infections in the postpartum setting. And this study shows that this spontaneous clearance of hepatitis C virus can be as high as 60 to 80% at the end of 5 years. These provide the argument that perhaps why don't we screen them later on? Because potentially by screening early and starting treatment for all, we may potentially over-treating these patients, right? But the counter-argument is also true that loss to follow-up following perinatal hepatitis C diagnosis is very, very common. And this is a recurring theme for multiple studies looking at this problem. And the loss to follow-up will range from 60 to 90%. And these loss to follow-up represent a huge loss of opportunity in treating childhood hepatitis C infections, which can, we know now, to develop into advanced liver disease silently over time. So then, should we be considering treating these patients while they are still pregnant? After all, it is a compelling argument by treating pregnant women with DAA, you reduce and prevent maternal-to-child transmissions. Potentially, you may improve outcomes by reducing both maternal and neonatal complications, and you can reduce the transmission rate of hepatitis C in the community setting, right? But there's also considerations of before we treat this pregnant woman who has found to have hepatitis C, is that we still need more data in terms of the safety and efficacy data of DAA in these populations. And cost effectiveness has also not well established in many countries. And this has led to recommendation by the WASLD that despite the lack of recommendations, the treatments during pregnancy can be considered on an individual basis between the clinicians and the patients. What does Hep C infected pregnant women think? Do they want treatment? This is coming from the large survey study of more than 600 HCV infected mothers coming from 3 countries, Egypt, Pakistan, and Ukraine, who is still at war. So this is pretty amazing study to me. And what they found is that when these mothers are being asked, would you like to receive treatment if the DAA is found to be safe during pregnancy? You can see that overwhelmingly, many of the mothers actually wanted to be treated. And the reason that they wanted to be treated is not so much for themselves, but really is to prevent the maternal-child transmissions. Of course, the caveat is a big if the DAA has shown to be safe. Do we have data that on the safety data on DAA? So in the recent meta-analysis, we found that the DAA is very efficacious. Very limited studies at the point of completing the meta-analysis. There's only 6 studies. You can see that the efficacy is great, similar of what we've seen in the general populations. The SVR rate is almost 100%. I would like to highlight one study, number 3, which is the SOC study. This is perhaps the largest prospective multi-center phase 4 study looking at the safety and tolerability of sofosbuvir and velpatasvir amongst hepatitis C infection in the pregnant setting. The interim result was presented in the AASLD last year after recruited 50 patients. What they found is that the use of soft-val in this population results in 100% SVR rate, 0% maternal to child transmissions, and there are 13 serious adverse events, of which none were thought to be related to direct-acting antiviral. So time is running out. So ladies and gentlemen, this is the key takeaway. So hepatitis C infection in pregnant and childhood remains a significant yet under-addressed barrier in the perspective of a global hepatitis C eliminations. Hepatitis C infection in pregnancy is linked to adverse outcomes to both mother and child, including increased risk of maternal to child transmissions and long-term liver-related complications. Therefore, universal screening of hepatitis C in pregnancy is essential because this represents the first step of diagnosing who actually has a hepatitis C and provide the foundations of looking for infant at risk of developing hepatitis C at the postpartum setting. And finally, DEA has showed emerging safety data in the pregnancy, and hopefully with more data, we will be able to look at this consideration of treating pregnant women using DEA in the pregnant settings. But certainly at this current stage, these treatment decisions has to be individualized. So with that, we thank you very much for your very kind attention.